Hi, good evening. I'm Dr. Philip Macmillan. I've been looking at COVID through the autoimmune paradigm for about 4 years now. And this is now April. Yes, just beyond 4 years was when we did our first presentation about the autoimmune pathology around COVID-19. And so I've been looking at the same thing now for 4 years. I've been looking at all the presentations of disease through that autoimmune paradigm. So I have a unique perspective on the pandemic. And just in case you haven't realized, I don't think it's over. Similar to Gert, I think the tsunami is coming. I just don't know when. And so it raises an important question that seems strange. How do the vaccinated die of severe COVID? There's a reason why it seems like a strange question, unless you believe that they don't die of severe COVID. At this stage of the pandemic, you have a very clear separation in terms of the numbers. You don't have as much ITU stay, and at the moment, you don't seem to see a lot of deaths around COVID 19, but it's not because it isn't happening. There is still something going on. So I'll be making reference to this paper, COVID 19 in the Netherlands Lessons from a Nationwide Query of Dutch Autopsy. It was just published in February of this year. So that's an important piece of information. I'll also be going back to some important understandings about what causes severe COVID 19, at least in the unvaccinated cohort. But before I go into that, I'd just like to remind you, as I said, I don't think this is going anywhere. We still have a way ahead of us and there's still work to do. So if you're interested in how to prepare for the next wave of COVID, please click on the link below, a discounted presentation. I've got some very good testimonials on it, and it deals with just a number of points that are relevant to keeping well with regards to COVID 19. Nothing is perfect, but the more educated you are, the better position you will be in. So click on the link below, and if not, just subscribe. So let's get back to this question about deaths and COVID. Here's an interesting thing. Just about a year ago, I did this presentation, the first full autopsy on a COVID vaccinated death. Now, can you believe that? In 2023, I think it was about April 2023, or maybe in February it was done, but I presented it in April. That was the first full autopsy. So I've been waiting patiently, and I've been looking out for further autopsies because I think it's extremely important. Without autopsy, there is no science. No matter what anybody tells you, you have to have autopsy to try and understand the characteristics, especially the histopathology of disease presentation. So I went, therefore, looking at the Netherlands presentation, and this is it here. So this is an autopsy study, a nationwide autopsy study, looking at the histology and the pathological reports in COVID 19, was published in February 2024. And so they were looking at, since the onset of COVID 19, autopsies have played a valuable role in understanding the pathophysiology of COVID. Exactly right. And so they were analyzing pathology reports around COVID 19, histology and cytology on a nationwide level. So this was a very, very important cohort, and they were looking at a total of 1,833 eligible participants. So this was a big cohort of patients. So what's the first thing that I do? I check to see whether or not they looked at the unvaccinated versus vaccinated, because they clearly went from, and I'll show you this here again, they went when they were covering a period of time between January 2020 and June 2021. So I know they would have started their vaccination program by this time. And so, therefore, my question is, well, what percentage of these autopsies were vaccinated? Well, let's see. I will do Control F, And you can see in the top of the screen, and there is zero. There is no word on this with regards to vaccination. So I know straight away that I'm not going to get directly that answer. But it's an important question. Why is it that this is such a major issue, I wonder? We do have to ask ourselves if there is a reason why this question is not being answered. Really, because autopsy is the foundation of Western medicine. If you are not doing autopsy, how do you know what is going on? What is the pathology? Do you need to adjust what your treatment modalities are? Is there a more effective way of treating things? Suppose the pathology has changed. Why wouldn't you expect the pathology to change? These are the questions that really I don't understand why they're not being asked more. So let's get back to the science a bit. So let me remind you as to what in an unvaccinated person causes severe COVID-19. This is how it works. You have technically three different categories, and it's all tied to interferon. And interferon is the signaling molecule that lets your body know that there's a virus around. It's like the alarm signals that go up. So if there was virus floating around, you see the flashing lights, it makes noise, everybody's on the alert, there is virus floating around. And so this was a study that was done in mice, but it really parallels what we see clinically. So here you have three different kinds of presentation. In this one here, they have early interferon. These are the people who had previously been exposed to coronaviruses. And so as soon as the virus comes, they recognize it. Even though the virus replicates, they have no severe disease. What was interesting is that as well, in people who didn't have an interferon response or a very weak interferon response, even though they had a big rise in the titer of virus, they still did not have severe disease. What caused severe disease was a delayed interferon response with the rise of virus, and then you had a very severe response because that alarm didn't go off early enough. And it's almost, as I said, it's the equivalent of someone getting down into the bunker for the president. It would set off alarms all through the US, all the way to the Pentagon, because it shouldn't happen. And so when a virus gets to the lung without an interferon signal, it overreacts, and this leads to severe COVID-19. And based on our research, we've looked at the autoimmune response that's triggered around that time, and then that leads to severe immune pathology and potentially death in some people. So that's the mechanism with regards to the unvaccinated. But in the vaccinated, what was puzzling for me is why would they not have an interferon response? Or more importantly, even if they didn't have an interferon response, they already have primed and circulating um, antibodies. So how does that work? Is it the same pathology? So let's go back now to the paper. So this is here looking at some details about the paper. What they found when they looked at the autopsy report. Now, the only thing that they did that I'm using to try and help guide me is that they've divided it into years 2020 and 2021. My presumption, and it may not be correct, is that in 2021, this cohort is mixed with some who are vaccinated, unless they specifically excluded the vaccinated, which I don't think they would have done. One of the first things that you notice is age of death. In the 2020, which was definitely all unvaccinated, was about 70. But in 2021, that age range has shifted down to about 66. So there is clearly a younger cohort, and they're not sure if it's because of their selection of autopsies. Maybe that was part of it, why it seems to be a younger age group. The other thing that is interesting is here in terms of disease duration. In 2020, it was really about from day 8 to about day 24. In that period of time, the patients would have died, and the average here is about day 11 or 12. In the 2021, that shifts upwards, and we're talking now to probably about day 12 or 13 to day 32. And the midline point here is probably almost day 20. So what's interesting is that if we were trying to therefore reduce the pressure on hospitals, that didn't work too well because people ended up being longer in intensive care, even though they presented later in 2021. And again, I'm making an assumption that that's because it could possibly be mixed with regards to what was the cause of death or whether their vaccination status. Additionally, here you can see from the paper when they looked at the cause of death, COVID-19 reports cause of death, and you can see here the primary 78% were COVID-19. Some people had circulatory, this is green, but of the COVID-19 numbers here, 50% of them had acute respiratory distress syndrome. That's the lung inflammation. This number, 15%, had organ failure, pulmonary embolus, and you can see it's going up. And other, not sure what other is, about 9%, had other causes in the COVID-19 group. So that's typical. That's what we would largely expect. Now, again, in terms of extrapolation of the information, here is the bit that I really want to get into because I want to know what is happening in the lungs. Why are the lungs shutting down in the vaccinated cohort? Why would it be similar or how is it different? And we still don't know. I mean, I'm telling you, this is not good enough. I'm yet to find somebody give me a logical explanation as to why this kind of research has not been done in huge numbers because we're still having vaccinated deaths across the world all the time. Why does no one want to study it? Anyway, let's look here at this image here. So this is now looking at time frames 0 to 7 days, 8 to 14, 15 to 21, all the way up to greater than 56 days. Then they're looking at the pathology. So this is diffuse alveolar damage, acute diffuse alveolar damage, organizing, and this is where it's close to fibrosis. These two are very similar. Fibrin plugs. They're talking about this is just general fibrosis of the lung. This is thrombi, microthrombi, and it goes all the way down to microorganisms. If it's blue, it means that the frequency is very low. If it's red, the frequency is very high. Okay? So when we look at this chart here, you start to notice that what stands out here in red is 8 to 14 days you having microthrombi. This is 66% the most important pathology that occurs in severe COVID-19. This is what causes patients to die. And when I do my presentation on, I'm planning to put together a comprehensive course on COVID. I'll explain why those microthrombi are so critical with regards to understanding the mechanism of death. It's a really important piece of information. Here we have again, they're looking through when there is no diffuse alveolar damage. What's interesting here, 0 to 7 days, 44% had none in that early part. And then as it goes along, you can see it by the time it's 56 days, it's 47%. There's acute diffuse alveolar edema that occurs. 48% had it in 0 to 7 days of presentation. The one that stands out that I was particularly concerned about or trying to work out about is this organizing diffuse alveolar damage. Similar to fibrosis, it's very advanced. So it doesn't occur normally quickly. It usually takes some weeks, but you can see by the second week here, 41% have this. I just don't know whether this is 2020 or 2021. My suspicion is that this is occurring in 2021. And that's the kind of thing that I'm looking for. Because what I'm trying to figure out is, do we already have an inflammatory process occurring in the lungs that may be autoimmune that then gets reactivated when they get exposed to COVID? And that would then explain why you're seeing more fibrotic longer term changes in the lungs in people who would have been vaccinated. You wouldn't expect to see that in the unvaccinated because it's quite an acute response. And where we are at the moment is that when we think about what is going on, if you break it down into groups, because of how disease occurs with COVID 19, severe disease I'm talking about, the unvaccinated with natural immunity are very unlikely to have that unless they have interferon autoantibodies, and then their interferon signal is not working, and they could therefore still be prone to severe COVID 19. What we don't know is, because we do hear that patients who have not been boosted are at higher risk. Now, what we need to understand is, does the interferon response change if they have already been vaccinated and then exposed? Why would that vaccinated cohort, even though they may have only taken 2 doses, why would they be more at risk for severe disease? And what about the boosted people? If they are boosted and they still had severe disease, what's the mechanism? And we'll only know this when we start to look at autopsies to try and make sense about it. So, going on back to this here, I'll show you another piece of the question that I was looking at. So, again, you have here a breakdown from the paper, and they're looking at the frequency of these changes. So, this is in percentages up to 50% here. Red is 2020 and blue is 2021. And again, as I said, I suspect that in 2021, there's a mixture of vaccinated and unvaccinated in the autopsies. So, in terms of no diffuse alveolar edema, they're about similar. Acute, you can see red in 2020. That fits. That's the severe presentation that caused people to come into hospital. It's interesting that it is much lower in 2021. But when we look at organizing or more fibrotic diffuse alveolar edema, that's more significant in 2021, which fits what my instinct is that the inflammatory process is occurring in the population and is exacerbated with infection. And so this is what I am wondering is occurring, and we need more autopsies to try and make sense of it. We can see here microthrombi are less in the 2021 cohort versus 2020. But again, pulmonary fibrosis is higher in 2021. And this is the question that I have been really interested in. Are we dealing with a low grade inflammatory process in the lungs that then gets exacerbated when people are exposed to virus? If that's the case, then our treatment modalities should change, because we're still using steroids, but steroids may not be the right approach. We may need to use different kinds of immunosuppressants. And would you want to catch that before the person gets COVID? Meaning that if there is a fibrotic process going on, do we need to know who those people are? These are all the kinds of questions that should come up in a normal situation. However, we are not in a normal situation. And sadly, for those people who know me, there is an elephant in the room. This elephant nobody wants to really look at. And as a result, all of science has been discarded because there is an elephant that nobody wants to touch. Here's the problem. Based on what Gert has been saying, at some point there is going to be one of those viruses that trigger this kind of response again. The people who are going to be most at risk are certainly the vaccinated cohort. Do you want to wait until it happens to understand it? Or are we better off studying it beforehand to prepare? That's what I mean about mitigation. I don't know what else we can do, but certainly Sitting, ignoring it, not doing anything different, to me doesn't make much sense. Let's hope that in 2024 and the years beyond, we'll never have a situation again where politics, finance, and all these other things influence the practice of medicine and the science of what needs to be done. Have a great evening.